Clap your hands now.
Hello, my name is WonMoon. I'm one of the developer of MSE, Maxillary Skeletal Expander. Back in 2003 or 2004, US FDA finally had approved the usage of microimplant for orthodontic patients, which was a very exciting news for all of us because some of us thought that maybe we can utilize them for anchorage purposes. In my perspective though, I thought that this would be a great tool incorporating into orthopedic corrections, class 2, class 3, as well as patients who need transverse correction. It was a very simple concept. Over the decades, we have been increasing the transverse dimension of maxillary arch by using a Hyrax device. So idea was, can we incorporate microimplant with a tooth-bone Hyrax, thus making it into a bone-bone device. So thus we can have a more meaningful, more consistent skeletal expansion. Here's our first generation device we created. As you can see, we have a typical Hyrax device we have been using for decades. And we soldered 4 tubes housing 4 microimplants, so thus making it into a skeletal expander. What do we call this? Well, we thought that maybe it's pretty clever to call it microimplant assisted rapid palatal expander. In short, we call it the MARP. Over the years though, we have evolved based on my clinical experiences and some of the feedback we got from our patients. So we evolved quite a bit into a sort of a new design. And nowadays, we actually have a prefabricated expander for more accuracy and consistency. However, though, I was not the only one who was thinking this way. All of us think alike. We're all orthodontists. We wanted to create a skeletal expander utilizing microimplant. So many investigators globally they came up with a sort of a similar design. Some of them even called it MARP independently. So the term MARP became sort of generic terms. And the problem here is the many different designs by different investigator and different treatment protocol resulted in different findings. So this became a massive confusion because some of the findings will contradict one another. So in order to differentiate myself from the rest of the pack, we decided to rename our MARP Maxillary Skeletal Expander, MSE, so that whatever we do with this device will be differentiated from the rest of the pack. So how is MSE different than the rest? Well, there are many differences. However, I'm just going to highlight the main points. One of the differences is we promote posterior force loading instead of middle or anterior force loading. Here's the reason why. In order to expand the maxilla, we have to overcome these structures here, zygomatic buttress bone and maxillosphenoid junction, both of which are positioned quite distally. Our typical expanders are usually positioned more anteriorly than these resisting structures. So if we had our way, we would like to have these expansion device further back. However, though, our limitation is the soft palate. So we must position this anterior to the soft palate. So our solution was to increase the AP width in order to promote more of a parallel expansion. So over the years, though, we found out that we have a good evidence support that MSE will actually give you a parallel expansion from the occlusal plane, like this illustration. Most of other expanders, whether it's MARP or Hyrax or other expansion devices, generally give you this sort of V-shaped expansion, more expansion in the anterior region than the posterior region. What else is different about MSE? I believe MSE is the only expander in the market right now, promotes bicortical engagement. What does that mean? Well, we want to avoid this sort of V-shaped expansion from the frontal view because traditional expanders will do this. Many of the other MARVs will do this. However, by engaging both cortical bone from the palatal side and as well as the nasal cavity side, as you can see that the micro implants are into the nasal cavity, we can promote more parallel expansion. And it's pretty clear that you can see through and through parallel expansion here with a good opening of the suture. Here's another illustration in 3D, generated from 3D X-ray. As you can see, parallel expansion all the way through. You can almost argue the expansion is actually greater from the nasal cavity side than at the alveolar, tentoalveolar region. And you can also see the expansion extend all the way up to the nasal bone area. And expansion also happens with the zygomatic arch here. So it's more of a mid-facial expansion rather than maxillary expansion. And bicortical engagement can create this sort of massive expansion with the mid-face. And here's another view, three-quarter view from the right side. You can also see all the perimaxillary sutures are being affected, as well as other surrounding structures. Here's another three-quarter view from the other side. You can see clear opening between the nasal bone and the surrounding bone. It's almost like a distraction-like expansion. So what are the advantages of having parallel expansion? Let's take a look at that. Well, as you saw, it's almost like a distraction-like movement. So what if we combine protraction device along with expansion? So it becomes more of a distraction-like expansion and distraction-like a protraction movement. So combining MSE with a face mask becomes a potent tool treating class 3 patients through growth modification. Here's one of the patients we have treated, class 3 patient. You can see the before with the black line, after with the green. You can see the tremendous amount of forward movement of the maxilla. We changed the A and B angle by 8 degrees in only a short period of 10 months, which is way beyond the scope of traditional face mask approach. That's because we're able to loosen up all the perimaxillary sutures along with the other structures in the mid-face. Here with the traditional tooth bone face mask device, we often get flare of the upper incisors in forward direction, which is not the desired movement. With the bone face mask here, through use of MSE, you can see upper jaw will move in forward direction, but teeth will actually move back the other way. So decompensating, which is one of the distinctive advantages of using MSE in combination with the face mask. How about nasal airway? If it's parallel expansion, you would assume that nasal airway will increase in width more significantly than a V-shaped expansion. And that's exactly what happens. See here, one of the younger patients who had the difficulty breathing. And after the MSE expansion, you can see a nasal airway became open. Year and a half later, this widened nasal cavity now became functioning nasal cavity with all the turbinates in place. How about older patient? Could we do the same thing with the older population? Absolutely. Here's a 30-year-old patient without the surgery. We're able to expand the maxilla. Here's the X-ray of the same patient. You can see through and through parallel expansion here with the bicortical engagement of the microimplant. How about 38-year-old? We're able to expand quite a bit here. You can see the size of the space here is larger than a tooth. And this is without any surgery. And when we look at the X-ray, you can clearly see all the implants are parallel. So this is a parallel expansion. You can almost argue the expansion is greater at the root tip than at the crown portion of the upper jaw. Here's 54-year-old. One time we thought that 54, it will be impossible to expand the maxilla without the surgery. But as you can see, we were able to actually skeletally expand the upper jaw. So here you can see through and through expansion again and parallel expansion in 54-year-old. So is MSE always successful? Absolutely not. Most of the time though. So let's do some troubleshooting. When do we fail? Most of the time when we have a failure is because of the lack of bicortical engagement. So this is very important. We have to get a bicortical engagement of the microimplant. Here's why. When we have both layers of the cortical bone engaged, the lateral force down here will be translated to lateral force up here. So that it becomes a more or less parallel expansion, causing less strain on microimplant during the expansion. However, when we have implants not quite reaching all the way up to the nasal cavity, the expansion force down here does not get linearly translated to up top and causes tipping of the microimplant and eventual strain and potential failure of the implant. So one of the reasons that, well, let's talk about why we are not able to get the bicortical engagement. A common mistake people make is usage of the motor driver. See, I promote using the manual driver instead of motor driver. Reason being, in order to engage two layers of the cortical bone, by the time we get to the second layer of the cortical bone, it becomes very difficult to turn the driver. If we have pre-measured torque motor driver, we'll not be able to deliver enough torque to penetrate through the second layer of the cortical bone. Of course, you can increase the torque level on this motor driver. And what's going to happen then, the continuous higher torque force will be applied to microimplant, eventually causing the failure. So what we need in order to create bicortical engagement is high level of torque, but in intermittent force, not continuous force. And motor driver cannot give you that. So this is why it's very important to use the manual driver, so you can apply high but intermittent force as you penetrate through the second layer. Another common mistake, not having well-fitting appliance. The body of the jack screw should be flush against the vault of the palate in order to have proper, adequate bony engagement with the microimplant. When you don't have that, obviously tipping will occur and cortical bone will not be reached with the tip of the screw, and oftentimes it will cause failure. How about not using the long enough screws? So obviously, if screws too short, you won't be able to get to the second layer. And this is another common mistake people make, especially when they're dealing with the younger patients, because it's younger patient, they feel that they should be using 9 millimeters instead of 11 millimeters and not have the full bicortical engagement. How about placing MSE too far anteriorly? Because the majority of other MARPs are designed in such a way that they're placed more anteriorly, those people who are used to using other types of MARP have a tendency to place MSE too far anteriorly. When that happens, you can see the bone thickness of the palatal bone is greater in the anterior region than the posterior region. So the screw won't be able to reach the second layer of the cortical bone, and this becomes a problem. So here's one example. None of the 4 screws were engaged into the nasal cavity, cortical bone in the nasal cavity. You can see the tipping of the microimplants. You can see bending of the microimplants. Clinically also causes a problem. You can see uneven expansion. You can see a microimplant tipping away from each other. You can see a microimplant actually being dragged through the bone and being bent. You can see a loss of the molar bands and tissue impingement. Not a pretty picture. This is not something you want. And when we remove the microimplant, you can see this implant was completely bent, and all of them have some sort of distortion. And because of all the additional strain, they have to suffer. So it is, again, very important to make sure that we have full bicortical engagement for better success. How about tissue impingement? Why does this happen? Well, we have to make sure that our supporting arms are clear away from the palatal tissue. That's because, unlike hyrax, where your expansion happens more at the bottom than the top, force loading for MSE is up on the palatal vault. So that oftentimes you'll get more expansion up top than down here, the area which is supported by the zygomatic buttress bone. So that uneven lateral movement, if you don't have, can cause tissue impingement if you don't have the supporting arm away from the tissue. Here also you can see 4 arms going in different direction, and this is the older type, and we switched over to this type now. Because the more wire mesh you have in palatal side, more chances you're gonna end up with a tissue impingement in one of the arms. So it is actually better not to have too many wire mesh near the tissue. So it's better to only engage upper 6s with a good clearance, minimum 2 millimeters. How about expansion protocol? Sometimes this causes failure because it's not easy to break through the mid-palatal suture in grown patient. So when things become difficult, when turning becomes difficult, oftentimes people will slow down the frequency of the expansion. But it should be quite the opposite. Older the patient, more mature the patient, you have to expand in higher frequency. We need more intersutural force to break apart. So we have to overcome this interlocking of the 2 halves of the maxilla, which requires tremendous amount of lateral force initially. Once diastema forms, then you can slow down. So those are the pretty common problems I hear from MSE users. So where do we go from here? What is our future development? Well, we certainly have to improve our design. One of the main ones that I've been working on is this here. Let's look at this wooden chopstick analogy. In order to split this chopstick, which is fused up here, generally we spread the chopstick from the bottom, which is not very hard to do. They split quite easily. Chopstick will bend away from each other, but eventually the fusion will come apart. However, if you try to split from the top here, it becomes much more difficult task. It takes tremendously more lateral force to accomplish the same thing. However, though, 2 halves of the chopstick pair will split evenly in parallel fashion. So analogy here is, this is sort of like the hyrax expansion with the bone bending, but quite easy to split. Doesn't require a lot of force down here. This will be more like MSE expansion, where we get quality parallel expansion, but takes tremendous amount of lateral force. problem with our current design is that we are using the jack screw that was originally developed for Hyrax device. So cannot apply adequate force level to split this fusion easily. So this is the typical jack screw being used for Hyrax device. So we need something more sturdy. So help is on the way. This is our new design with a much more powerful gear in the middle. So we can apply much higher level of force to break apart the interlocked sutures. How about treatment of sleep apnea patients and reduce the CPAP usage? About 80% of sleep apnea patients are undiagnosed. So I've been hearing testimonials from my patients over the years. After MSE expansion, they stop snoring, they can breathe better. They never knew that they had breathing problems. So we like to actually come up with some objective data by measuring airflows and blood saturations and so on and so forth. So we can actually set up a protocol dealing with this patient population. How about orthopedic corrections of adult patients? I mentioned earlier, growth modification of a class 3 patient is possible with the MSE and face mask. What about adults? Can we do the same thing? So as you can see in this illustration, it's almost like destruction, like expansion. So can we apply AP force, forward force, and actually position the maxilla in forward direction? Force the maxilla to grow in grown patients. So creates sort of like a surgical movement, a destruction-like movement without the destruction. So there are a lot of unknowns, a lot of exciting possibilities with MSE. And one by one, we like to tackle. And someday, we'll have more answers and better treatment protocols for some of these impossible cases. Thank you.